Welcome to Healthcare de Jure, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare de Jure is brought to you by High Tech Answers and Healthcare Now Radio, part of the Answers Media Network, and is sponsored by the law offices of Myrick O'Connell. Now here is your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Tom White, CEO and founder of Phynd. Welcome, Tom.
Hi, good to be on.
Well, it's great to have you on. Before we kind of dive into our main topics of discussion today, would you be able to give everyone a little bit of an introduction in terms of who you are and what you do?
Sure. Tom White, CEO and co-founder, actually, of Phynd Technologies. And this is my third software company. First one was a real-time news service. Started out of grad school. In grad school, I was studying Arabic and Middle East studies and got engaged at the time. And my wife and I decided to not make the move to the Middle East, and we stayed in the U.S. And I turned around and started a software company that was a real-time news service. And then we shifted over to the healthcare market and built a real-time communication system for the communication of results from hospitals, from radiology in the lab, out to the referring physician community. And that was purchased by Nuance Healthcare in 2007. My father's a retired nephrologist, so that's where the healthcare interest comes from. And partner in my businesses has been my brother, Peter White. He's co-founder of Phynd as well.
So being the son of a physician, I can see, where the interest can come from, but, was there anything in particular that drew you into the healthcare field other than kind of that familial connection?
It's a good question. Once my father so after our first software company, which was a news service, worked with Dow Jones and Reuters and different companies, we took a step back and said, what do we want to do next as far as a new company? And my father really stepped in and said, let me map out the healthcare industry from his perspective and where there were pockets of opportunity. And so, he was very, very helpful in the decision process around where to kind of target for our new company.
So is it too prying to ask kind of what his map looked like from the physician perspective?
Well, so it was all about communications. And so his point of view was that physicians in general have a difficult time of communicating, whether it's the personality of the physician or where they're positioned inside the hospital itself. And so he said any tools that help the free flow of information, and this was results, these were critical results out of radiology in the lab, was a positive thing. And he gave us, certain, points of view about how to interact with providers who are receiving the messages, making sure it was easy for them to digest and consume. So real helpful information kind of on both from an architectural, looking at the health system, and then also at the ground level, what a provider wanted to consume and digest as far as real-time information and what devices they use.
I know you said that the kind of your first foray into healthcare was that communication, and now, if I recall correctly, you're kind of focused on provider tracking challenges. So, are those kind of two sides of the same coin, or somewhat of a natural extension of each other? Or kind of how did the concepts that you've worked on connect with each other?
Yeah, it's a good. So the provider communication challenges that we were tackling with our first healthcare company was called Vocata, was a symptom of the broader provider information management issues. So hospital systems, health systems don't have a good view into provider information. So they've got great patient tracking systems. So and those are Epic and Cerner and Allscripts and all the different EHR vendors. They basically track the patient from admission through discharge. And then they have great payer systems, so the claims adjudication process, so how they actually get paid. But there hasn't been a system that holistically says, here's a provider, here's what they do, where they work, what networks they're in. All that information is not captured in one single system that then integrates at the care coordination level, at the revenue cycle level, at the network management, so how they manage what networks the provider's in, and then on the marketing side too. So yes, the first company was tackling a symptom of bad provider information, and now we've gone to the root cause. So we're really trying to tackle the issue at a big level.
So could you kind of provide some more insight in terms of how you're going about trying to tackle that complication? Because also being on the outside, I see the issue of not being able to have a holistic view of what provider is participating where on the outside of transactions, because it's I think one piece of it is it delays a transaction because you have to go through the whole process of making sure you're getting onto all of the appropriate payer plans and kind of all those other components. So I think getting an understanding of kind of the root of the problem and then some of the directions you've gone in to try and solve the problem would be very insightful.
Okay. Yep. So the way that the IT landscape looks at provider information historically is that there are credentialed providers, right, that work in the hospital. They're privileged to do services in and around the hospital setting, and there's a credentialing system for them. And that's how they historically they would track their providers. Now, there's a whole group of referring providers that refer patients into these specialists or into these doctors that are credentialed that aren't tracked at all historically by health systems. They may be inside the EHR as a piece of data. They may be in the rev cycle system as part of the billing process. But each department had a piece of information on that provider. So rev cycle has the revenue billing address. The EHR may have their direct address for communication. The radiology will have the best fax number. The lab will have the best phone number. So everyone's got a piece of information on a provider, and there hasn't been a system that collapses all that data into one profile that then gives the health system multiple views into the same provider profile based on their agenda. So if I need to communicate a care issue, I can look at that information I can look at one profile and see that data. If I need to bill for a claim, I can make sure that the rev cycle address is up to date within that same profile. If I'm a marketing person and I'm trying to project out some marketing information, whether it's a video, photo, a Google map, whatever, I can do that within the Phynd profile too. So the idea is to build one system with one profile for every provider a health system interacts with. Make it simple for them, and then have lots of data in there.
And were you finding particular barriers from wanting to do that? Obviously, it sounds like an extremely good idea to help, and it would benefit, basically every side of the equation. So, kind of as I said, were there any particular reasons for barriers, or was it just a matter of no one had focused on that issue?
It's really just the legacy of the healthcare industry and how it evolved from a technology perspective, in that there's been independent systems sold into every different diagnostic. So radiology has a radiology information system, the lab has a lab information system, cardiology has a CIS system, there's an EHR, there's a credentialing system. So you can look at an IT, you can look at health systems IT landscape, and you could see 80 or 90 or 100 different systems. And each one of them has historically a piece of data on the provider. So it's just the way the industry kind of grew up. And then as the EHR has taken over more and more operations inside a health system, it's become important for them to have good provider information, but they weren't designed to manage provider data. They're designed to manage the patient process, the patient journey. And so it's an opportunity for us. It's presented an opportunity for Phynd to stand next to the EHR and say, we'll handle the provider data model. You handle the patient data model, and let's coexist together in a friendly environment.
Right, which kind of that description you just gave really seems to be a microcosm of what you had a little bit described in terms of what drew you into the space based on your father's diagram anyway, which was, it's a very complex, convoluted system, and it just feels like every time you look at, an issue that's being addressed or solved now, it all comes back to kind of what you were saying, which was the system just grew up in a fragmented manner without trying to think about how to make all the different components work together from the start, but it would be just throw a solution at something and then we'll figure it out later on down the road.
Yep, that's exactly right. And then, as health systems have evolved and IT has evolved, the customers are looking now to shrink the footprint of vendors, right? So they don't, instead of having 100 vendors, they'd like to shrink it down to a smaller number. And so Phynd helps them do that by collapsing a bunch of different smaller systems into the Phynd platform.
So as you go about, as you said, collapsing that information, what are some of the efficiency benefits that are found?
So if you one of our clients found that they had 80 different systems that were managing a piece of provider information. And so what they've been able to do is they've been able to collapse basically to stop, and a lot of those were Excel spreadsheets, Access databases, small kind of IT systems that a department had purchased on their own. And so they've gone in and they've systematically enabled these departments now to use the Phynd profile to manage the same data set that they were emailing back and forth via Excel to different departments. And I was talking to somebody that works with me at Phynd today about it, but it's amazing that these multi-billion-dollar revenue businesses manage hundreds of millions of dollars on spreadsheets still, basically, and that's how they manage provider information. So whether what network they're in, so what ACO, what clinically integrated network they're in, their health plans, all this important operational information has been managed and still managed on spreadsheets. And so the idea is collapse these flat files, these different spreadsheets into Phynd, and start using the workflow tools that Phynd has to update and manage that provider information, and then flow it back in. So it's bidirectional into their core systems.
Right, and kind of what you just said was what was immediately popping into my mind, which was it's hard to believe, as you said, that these gigantic businesses were managing, and probably to a large degree, some of them out there are still managing so much of their business on a simple spreadsheet where you have increased capability now of having jointly managed spreadsheets and being able to have people collaborate on it, but it's still a kind of a unitary type document on the whole.
And the reason is that, one of the reasons I think that it is that the nature of healthcare has shifted in the last 5 to 10 years because of the Affordable Care Act and the move to ACOs and the CINs, and so that the CEO and the CFO are driving these new economic models. So they're building these alliances, networks, to really drive revenue into the health system. But the IT landscape, the IT backbone, is not designed for that. And so spreadsheets have basically been built to fill that gap momentarily, and then Phynd is kind of coming in saying, here's a better way to actually operationalize your ACO, operationalize your clinically integrated network through the Phynd platform, and not use spreadsheets.
No, I think any improvement there would be beneficial. And for those of you just joining, I'm talking with Tom White from Phynd. We've been talking about provider tracking. And kind of, Tom, you've just been talking about how the transition to clinically integrated networks or accountable care organizations is helping, I think you said, to accelerate the need to manage this information about providers. So what particular aspects are you seeing from the ACOs or the similar type models that really call for this transition that might not be so obvious?
Well, so all health systems are moving to these at-risk contracts that are value-based care contracts, and so it started slow, and it's really gaining a lot of momentum right now in the marketplace. The average provider, it participates in about 20 plus healthcare plans and networks, and that about 2/3 of all providers have joined and then left one of these networks. So they've tried it, they didn't make what they thought they would potentially, and then they've left and joined a different one. So there's a lot of puts and takes, a lot of people joining and a lot of people leaving these networks all the time. So it's a high transactional model, and that the important thing is that health systems need to know who's in and who's out on at least a monthly basis. And so the notion of a simple roster management has become difficult because there's so many different people that are coming into markets and leaving markets, And then these health systems themselves are going out, and our clients will have 10 or 12 different networks that they've either built or are members of that are narrow health plans. So they're going to the local employers, the big employers, and saying, we'll build a custom health plan just for you with our doctors, and we'll add some referring doctors into it to cover your employee base. And so it's been really difficult for health systems to manage the both the participants, the providers that are in the plans, and then how they tier the plans based on the economics in their markets.
Right, and it kind of that movement of providers that you're describing feels like it is somewhat increasing. I don't necessarily have any data or any real drive behind it, but it just feels like there's, the whole concept of in the workplace, it just seems like there's a more openness to changing positions with some degree of frequency. And it sounds like that is part of the challenge as you were describing it, which is you can have people going back and forth, whether it's in or out of different networks, which maybe doesn't mean they've changed where they're working, but layer that on top of it. And it does seem really essential that you get a much better handle on all this information.
Absolutely. And it's not just about providers. It's also about the locations as well that a health system offers. And that's a really new trend, in that most health systems have many clinics. They have radiology imaging centers. They have colonoscopy centers. So they have these different locations that actually do procedures and tests. And so they are the provider. And so from a consumer perspective, consumers want to be able to look, go to a website, do a provider search, or on their phone, use an app, and find the right provider with the right health plan, and it could be the location, and then actually book the procedure or test. So it's real important that health systems can provide that data from a data model perspective out to their website. So one of our clients is Duke University, and the Duke Health website allows you to go and search real time on providers, and you can type in clinical friendly terms like ALS or whatever the term may be. And then you can also search on locations too. So you can look up the same procedures in a location environment. So it's about having a really, really broad and deep data model around providers and locations that can serve up all this complex information about health plans, networks, clinical terms, things like that.
So actually that deep data background that you were just referencing brings to mind another question, which is, how much are the systems or the payers collecting this full scope of information, and how much is encouraging them to focus on this now that there be a kind of a centralized means of collecting it?
It's an interesting question. So most health systems have a data warehouse. They've gone in, they've built these kind of deep data warehouses that they can do clinical informatics, and they can really look at trends and patterns and information. So a lot of hospitals have that in place. What they don't have, which is the area that we really help a lot with, is operationalizing data around providers to make their operations more efficient, to help them move to value-based care, and also to present themselves for the rise of consumerism, because consumers are searching, every day now for providers and in different tests and procedures. So hospitals have done a good job on the data warehouse side. We think that there's a lot of room for them to make up on the operational provider information piece.
In thinking about, kind of taking off that, the operational piece, what are the different ways that you can encourage people to actually collect it and then collect it in a more readily usable format? Because I've got to imagine if you just, if you're presenting someone or a system with, okay, here's more information that you need to get, the first question back will be like, okay, well, how do I go about doing that then? Because everyone always, typically, at least I should say, most people want things to be made as easy as possible.
So what we do, a big part of what we do is the Phynd application, which is used by hundreds of health system employees as they engage with the provider. So they're it's what we call the front lines of the operation. So the folks in registration and scheduling, the folks in the ancillary departments like radiology and the lab, Those people are talking to providers every day, and they're receiving orders for tests and procedures or new patients coming in inbound. And at that point in time, they can actually say, oh, and your provider's information is what? Or they can say, what is the fax number to the provider that we need to fax back this result to? So they're double checking that information. They do that anyway right now, but they're losing it because they don't actually take that information and put it back into the IT backbone. They just basically keep it inside that department. With Phynd, they can actually take that update, put it in Phynd, and it updates all the systems across the entire IT landscape automatically.
Right. No, and that alignment, I think, is one of the keys. It's I don't know why it took me this long to think of it, but it's obviously for a different type of system. But in my firm, we just got an updated CRM, which I'm going to butcher what it stands for, but I think it's Contact Resource Management. But it's a backbone program that allows if one person enters a contact, and anyone can then search for it, and if someone has the same one, you get linked to it. And if one person updates that contact, and whoever's linked to it then automatically gets that same information pushed out. Hopefully that's an accurate comparison of as you're saying, it allows everyone to have access to the same information, as opposed to Department A having half of the picture, Department B having another quarter, and then smaller pieces sitting out there. And then, as that information changes, they're not all getting the benefit of that.
Yeah, that's a good observation. I mean, I think that conceptually you're right on, that it's about taking, hospitals have great data. They just don't share it well. And so allowing them to update Phynd, that data then gets pushed out to all the core operational systems, and everyone benefits from a better fax number, better phone number. Because care coordination is about the devices. It's about phone, fax. It's about pager, cell phone. So all those things are very critical in the process, and it's just about harvesting that data from all the front lines in the organization is what we do.
And thinking about that kind of data harvesting and just coordination of it, what impact or what role is the consolidation that's been happening in the healthcare industry having on those efforts? Because I think we've seen a lot of hospitals gobbling up provider groups, or the hospital systems themselves coming together.
Yep, it's so frenetic right now on the purchase, acquisition, integration piece of provider groups and health systems. They can't keep up, so they never know who they don't know who a provider for them really is and what their affiliation is, because it changes so often based on acquisitions. So again, part of what we do, we have all providers already pre-built in the Phynd system. So we have the Phynd. I should have explained that before, but we have this Phynd network, which is all providers that are licensed in the country as part of a private network that we manage. And when our clients start using Phynd, we layer in these base profiles into their data to create this kind of super profile, if you will, of provider information across all of their credentialed, referring, anybody affiliated or non-affiliated that they want to track is now in their system. So it could be 80,000 providers on average, let's say. And as they roll in new systems, as they buy a new group, they buy a new health system, they merge, they can immediately upsize their provider population from the Phynd network. So it gives them this real-time view of who the providers are, because we have everybody already in the system.
Right. So kind of, as you said, it gives you a base to work from that you can then kind of refine as you're updating your own network. So believe it or not, we're already almost out of time. So I just want to ask you one closing question, which I've been liking to ask guests recently, which is, what is your bold prediction for how the healthcare industry is going to change in the next few years?
From my vantage point, the payers are going to be less involved in the creation and development of health plans, and they're going to be more the bank. So they're going to be more driving the economics around payments, and they're not going to be the ones who actually create networks. So that they'll get out of the provider management space and more just into the financial side of the equation. and less into the marketing too as well. So you'll see payers kind of move back a little bit back away from the consumer side.
Yeah, no, that'll be definitely interesting to keep an eye on. And as I just mentioned, we are already out of time. So I want to thank my guest, Tom White, for a great conversation today.
Thanks, Matt. And nice to meet you. Appreciate it.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.